Good morning, everyone. Welcome to our June Common Spirit Grand Rounds. My name is Dr. Barbara Martin. I serve as our System Senior Vice President for Advanced Practice. And I am thrilled with the panel we have today. As you can see from the slides on the screen, this is our most ambitious interprofessional grand rounds to date. And we really were purposeful and intentional in ensuring we had the voices of all team leaders in the space of mobility and frailty. So really excited today. This is the second in a series of grand rounds focused on our American Hospital Association age-friendly work that is led by our executive sponsors, Prentice Lipsey and Kim Kudron, and really excited to hand it off here pretty quickly to Dr. Margaret Cecil, who will be our moderator. She serves as our Systems Vice President for Advanced Practice Acute Care Services. She is a duly board-certified nurse practitioner in acute and adult medicine, and she will take it from here. And thank you, Margaret, for leading the efforts for today.
Thank you so much, Barbara, and thank you to everyone that is joined today. We are each going to introduce ourselves out of respect for your time today as we take on our different area of expertise in this clinical presentation. So these individuals that you see throughout our presentation today are the amazing people that really brought that time, talent, and expertise that Barbara was mentioning. And we're really excited for you to get to meet each one of them today. So with that, I'm going to pass it over to Kim Kudron for our reflection.
Good morning. Thank you for allowing me to do the reflection today. This is an excerpt from Pope Francis. He was speaking to the Italian National Federation of Professional Nursing Orders in March of 2018. And even though he was speaking to nurses, I'm going to confidently extrapolate these sentiments to all healthcare providers of our frail population. Being in contact with physicians and family members, in addition to the sick, you become in hospitals, in healthcare facilities, and in homes, the crossroads of 1,000 relationships which require attention, competence, and compassion. Before the uniqueness of each situation, indeed, it is never enough to follow a protocol, but a constant and tiresome effort of discernment and attention to the individual person is required. All this makes your profession a veritable mission and makes you experts in humanity. Thank you to Pope Francis.
Kim, thank you so much for sharing that reflection. And I love just those last three words, experts in humanity. Each one of those panelists of us that are on here and each one of those joining the call or watching this recording are experts in humanity because of the beautiful professions that we have chosen to serve. So Kim, thank you for that. With that, we'll jump into our objectives for today. Our three objectives that we are going to walk through with you, first in some didactic conversation as well as a case study, is describing the 4Ms and recognizing really how do you take the 4Ms and put them into clinical practice with a focus on mobility and frailty, to distinguish between robust and frail individuals, and to build inpatient and outpatient treatment plans on mobility and frailty using the 4Ms, again, with that focus on mobility and frailty. So we are going to have some interactivity in this panel discussion. So with that, we're going to go to our first poll. And if you went to the delirium session, you may know the answer to this. But for our 4Ms, as a part of age-friendly, what do the 4Ms stand for? Let's take a moment for you all to answer. What do the 4Ms stand for? And John, you'll just let us know when you feel like we've got a good number of the individuals that have joined the call. Well, they were fast. All right, 82%. Nice, what matters, medication, mentation, and mobility. I really wanted to see if there was one person who said they were going to put the Minnie Mouse, Mickey Mouser just to be silly on this morning, but nope, nobody was feeling that silliness today. Thank you guys so much. You're right. What matters are medications, mentation, and mobility. are our 4 M's as a part of our age-friendly discussion. And we'll be focusing on mobility today, and I will pass it off to Dr. Mary Spivey. And Dr. Spivey is a board-certified geriatrician who attended medical school at Creighton University and was oops, hold on. I apologize. This is what happens when you share your screen. And who is particularly during her 7-year tenure as an assistant professor at the University of New Mexico. Dr. Spivey has extensive experience in geriatric primary care, post-acute rehab, and outpatient consultative medicine, and is currently working at CHI Health in Lincoln, Nebraska. Dr. Spivey. And Dr. Spivey, you're on mute. We're all trying to be very careful about.
Thank you. Yes, I appreciate that. Yeah, so what I am going to talk about first is reviewing kind of the 4 M's and why they matter to us. I know we've all probably heard data and statistics on the silver tsunami, and we all know that people in the US are aging at a high rate. We know that 1 in 5 people in the US will be 65 plus by the year 2030, which is just around the corner. We also know that fragmented healthcare systems put our older adults at risk for having poor healthcare outcomes. So because of these things, the age-friendly healthcare systems were created to help optimize the care of our older adults. The development of the age-friendly model researched multiple areas and found the 4 M's of matters, mentation, mobility, and medications to be the highest value areas for clinical impact. So to go over those 4 M's, we talk a little bit about what matters. So this is choosing person-specific health goals and monitoring of care preferences. This can be particularly important in people with multimorbidity, as sometimes when we are going by guidelines-driven healthcare, this can kind of miss the mark on people's specific goals and produce non-holistic healthcare for our patients. With medication, we want to be sure that we're using age-friendly medications, so avoiding things on the Beers list, dose adjusting medications as needed due to people's renal function and water to fat ratios, and deprescribing medications as they're no longer needed or could potentially have side effects. With mentation, we want to make sure that we are working on the prevention, identification, and management of depression, delirium, and dementia. We know that all of these factors don't occur in isolation, and that actually each of these is a risk factor for the other. So we really need to look at these as a whole. Lastly, mobility, which is what we're going to talk about today in terms of the 4 M's. The age-friendly healthcare system describes mobility as an important factor in encouraging safe daily movements. We knew that decreased mobility is actually associated with all sorts of adverse events: functional decline, depression, cognitive impairment, increased hospitalizations and costs, as well as mortality. So with mobility, we want to talk about moving safely to do what matters to the patient, keeping that first M in mind of matters. We want to ensure early, frequent, and safe mobility and set mobility goals in all settings. So whether you're at home, whether you're in the hospital or rehab, we want to have daily mobility goals. And regardless of those locations, ambulating 3 times a day is an important goal. We think about this most in the hospital, but it's important to other places as well. As we know, we encourage our patients in the hospital to get up and leave the room or get out of bed for meals. We also want to do that in individual spaces. I've seen lots of patients who live in their recliner and don't get up for anything, and it is very important for them to be getting up as well. We want to be sure that we're assessing and managing impairments that could reduce mobility. So pain, strength, balance, and gait, high-risk medications, as I talked about, and utilize our colleagues in PT and OT to work on mobility and functional deficits. They use multiple screening tools to identify these deficits. Some of the screening tools that we can use for mobility include the time to get up and go, the Johns Hopkins highest level of mobility scale, and others. And for function, we in geriatrics, and I think with PT and OT, use the CATS index of ADLs and the Lawton instruments for IADLs. And then lastly, we want to be sure that we're addressing home safety as well as other risk factors for mobility loss. So risk factors such as dementia, delirium, fear of falling, and visual and hearing impairment. So we know frailty, it has a high prevalence, particularly in certain populations. We estimate that in community living older adults, about 5 to 17% of people may live with frailty. That can be higher in certain populations, as I said, up to 40% of people with cancer and 50% or more of patients who are older than 90 years old. Frailty is multidimensional. It doesn't occur from one organ system. It develops due to aggregate losses across multiple systems, and it's dynamic. You can move from one level of frailty to another. So from robust to pre-frail to frail and back. This frailty is related to changes with aging and multimorbidity, although I wouldn't call it normal. It is common, particularly with age, as we mentioned. There is a decrease in physiologic reserve and function that happens with frailty, which leads to an increased vulnerability to stressors, and it is a harbinger of adverse outcomes. We already talked about some of those with hospitalizations, disability, and mortality. So there are two kind of main types of tools that we use for frailty assessments. So generally you have either the phenotypical or physical type of frailty assessment or the deficit accumulation or index frailty. These are measured in different ways. The one I'm going to use today for our purposes is the frailty phenotype. The original phenotype was created by Dr. Linda Freed, and it includes areas of exhaustion, weakness, slowness, low physical activity, and shrinking or weight loss. And we grade these on a robust to frail scale. 0 of those 5 options is robust, 1 to 2 is pre-frail, and 3+ is frail. This is just a schematic that kind of talks about frailty in terms of a recovery model. So as you see in patients who have normal aging in red, they have, normal aging in green, they have kind of a robust response. Even with a minor illness, they still have essentially a large amount of reserve left, and they kind of recover back to their baseline. In patients who are frail, down in the red, we see that their baseline reserve is quite low. When they do develop even a minor illness, their functional status drops significantly, takes much longer to recover, and then they don't recover to their original baseline in most cases. Similar to the functional capacity, you see the same slope and rate in cognitive function as well. So here's some of the risk factors for frailty. I don't think any of these will surprise you. Things like advanced age, low socioeconomic status, smoking, pro-inflammatory markers, cognitive impairments, a lot of the things that we've already spoken about. When we're doing, when we talk about frailty assessments and evaluation, currently there's no regular screening guidelines for frailty. Some places recommend that persons over 70 or those with chronic disease or weight loss of 5% should be screened, but there's really no guidelines at this time. We know that for frailty assessment and treatment, a comprehensive geriatric assessment is effective and really kind of the gold standard for assessment and treatment. We want to be sure that when we're dealing with frailty, we're using a multidisciplinary team to make sure that we're assessing multiple areas, medical comorbidities, polypharmacy, fall risks, hearing and vision, as well as focusing on those non-medical things like social determinants of health and environment. Frailty screening is less common, I think, in our daily general practice as outpatient, but it is increasingly being used by specialists, particularly in oncology and surgery. The scale on the right of your screen just kind of, it's called the frail scale risk assessment. And it's a commonly used one in clinical practice because it's kind of easier to identify and just ask questions rather than using specific measurement tools. So frailty and hospitalization. We know that people who are frail have increased risks during hospitalization. We already talked about increased mortality, functional decline. They're also at high risk for delirium and pressure ulcers. They have a very high risk of admission to the ICU, which is not surprising, as well as a high mortality in the ICU with up to 30% of frail patients in the ICU dying. Frail patients are also, although they have such a high risk, less likely to have a palliative care consult compared to those with dementia and cancer. So we want to be sure that we're considering this while people are in the hospital so that they're getting the appropriate assessments for their problems. On the right here is kind of a trajectory of care for frail individuals that we can kind of look at, moving from a primary prevention of frailty as an outpatient to tertiary prevention, thinking about primary prevention as people advance in age, then thinking about secondary prevention as people start to develop more disease processes, tertiary prevention kind of when we start to see those disease process and those in and out of hospitalizations, might be some iatrogenic effects of hospitalization, and eventually to death. And we want to be sure that we're getting that palliative care consult, as with all chronic diseases, as early as necessary. Okay, so we'll move on now to our next poll. If people want to read this, which of the following are efficacious in the treatment of frailty? So this was kind of multiple choice. It looks like most of you, almost everyone chose exercise. So that's the huge one, and kind of what we're talking about today with mobility. Hormone supplementation actually has not been shown to help with frailty. It's hormones can be low in people with frailty, but we haven't shown that supplementing them has been helpful in a consistent way for the evidence-based. Polypharmacy reduction is helpful. Protein and calorie supplementation is helpful, particularly combined with exercise. And then psychosocial engagement is very important. Right, now we'll talk a little bit about our case study, and we'll all kind of go through our parts here. This case is based off of a patient that I have seen in clinic, and patients that I know we've all seen throughout our courses of treatment. So this new patient, her name is Norma. She's 77 years old. She has diabetes, hypertension, chronic kidney disease, OSA, stroke, osteoarthritis, depression, and dementia. A lot of this chronic diseases that we see. I'm seeing her in clinic because her PCP is concerned that she's had these increased ER visits and hospitalizations, and he's recently diagnosed her with dementia. So just to kind of review, she's had 4 hospitalizations in the last 3 months, including one where she had a fall and a UTI, another with a fall and a hematoma to the back of the head. The third, she had hospitalization with encephalopathy in the setting of hyperosmolar hyperglycemic syndrome. She also had a UTI and weakness. And then 2 weeks prior to being seen, she had been hospitalized with weakness and multiple falls. We're all familiar with this patient. So we'll talk a little bit about some of the evidence-based recommendations. So there were some guidelines published in 2019 by the International Conference of Frailty and Sarcopenia Research. We've just listed their strong recommendations here. So the first is a multi-component physical activity program. When you do refer to physical activity, you want to refer to programs with resistance training. When we're thinking about a comprehensive care plan, we want to be sure that we're addressing polypharmacy, sarcopenia, weight loss, and fatigue, as well as being sure that we're offering those social supports that are so important to patients. So here in the clinic, this is kind of what we see when we're seeing her. So she tells us from a 4M's perspective that what matters the most to her are her cats and never living in a nursing home. Regarding mobility, she's obviously had many falls. With mentation, she has both depression and dementia. Medications we'll kind of get to a little bit, but you can see here she's on 17 medications, some of which are as often as 3 times a day, which is particularly difficult for her with her dementia. For her diabetes, she has frequent highs and lows. So, she was admitted to the hospital with HHS, but she's also had several blood glucoses in the 60s and 70s, despite being treated on insulin. She also likes to hold her insulin when she feels like her blood sugars are low, and she'll take extra insulin when they're high. She's taking 70/30 insulin, which is kind of a higher risk medication with inconsistent eating patterns. She thinks her falls are due to leg weakness, even though she uses a walker. She also has urinary incontinence and a pressure ulcer. She has hearing and vision loss. And as I mentioned, she's missing medications, even though she's using a pill pack. So my initial plan when I saw her in clinic was to change her 70/30 insulin to once daily insulin. So we did once daily long acting as well as once daily mealtime insulin. We initially started a GLP-1, although she didn't tolerate that, given her chronic kidney disease and other comorbidities. We started some vaginal estrogen to address her incontinence and frequent UTIs. And her medications were changed from multiple daily doses to once a day, including the discontinuation of hydralazine, which has been linked to significant orthostatic changes in older patients. We added to her already existing PT and OT that had been ordered during hospitalizations, a nurse who could do wound care and also help manage medications, and encouraged her to consider going to the senior center and increase her socialization. So now I'm going to hand off to our physical therapist, Kim, who can go over kind of the roles of physical therapy.
Thank you, Dr. Spivey. Okay, so switching gears, putting Norma on hold for just a minute, we'll get to her again. The role of physical therapy is a vital component to the management of frailty in our elders. Physical intervention can start, of course, in the hospital, like what was mentioned, transition to home or skilled care and rehab, and then even a transition to outpatient physical therapy as needed. So just looking back briefly at the 4 M's that we've discussed already, incorporating these seamlessly into the physical therapy focus of care, what matters? And like we said, asking for specific goals tailors our treatment plan. If it's important to the patient, it's important to us. And if it's important to them, it drives their participation and their motivation to interact in physical therapy. So for Norma, her goal is to stay living at home. What brings her joy is her cats. Once in the home, though, for home care side, we're going to dive deeper into what this really means to her and how we can keep her home. Medications. So physical therapists also are looking at medication reviews pretty closely. It's important to review these, be mindful of the side effects and how these are going to affect how the patients are going to participate with physical therapy. So if we're looking back at Norma, a couple red flags that come to mind for me if I'm reviewing her history is that she's on furosemide. We all know that's going to increase her frequency and her urgency for urination. So the key, I think, for her would be in the home, accessibility to her bathroom. How far away is it? Is she safe to use her walker? What is her gait speed like? Is she going to get there on time? Can she manage her lower body clothing? Is she able to toilet and toilet hygiene? So other things besides physical therapy, then we're going to be pulling in occupational therapy to help us with that, with those guidelines. So medications. How will our frail adult, or excuse me, mentation, how are our frail adults going to respond to our teaching and to our home exercise program that we're going to be giving them? Excuse me. Do they have a social support involved with them that can assist them with home exercise program? Do they have finances available to support extra care in the home if able? So if we're backing up to Norma again, she's living with her husband. It says that they're financially stable. What is their social circle like? She has been diagnosed with depression and dementia, so we might be making suggestions on caregivers and companionship for her, recreational activities to stimulate mind, puzzles, bingo, card games, but also considering caregivers for respite for her husband. We know if he can get a break from caring for her and come back and be refreshed, then he can be the best caregiver that he can be. I'm looking too to see if her husband is going to be able to guide her through her exercise program, or maybe those paid caregivers would be able to do so, because we know that carryover is going to be so important. And lastly, and really so importantly to physical therapy, is the mobility piece. Evaluation of the whole person is the key to determine the appropriate interventions that we're going to be picking and choosing. As a general goal, it's increasing strength, endurance, range of motion, flexibility, balance, decreasing pain if possible, and of course, preventing falls. So if we're looking at Norma again, she's had repeated falls and weakness, even though she's been using a walker. We're going to focus on her gait patterns with the walker, make adjustments as needed, looking at her balance because she has had falls. And strength training to improve her functional transfers, her ability to manipulate stairs, her bedroom's on the second level. How can we move her from a frail status to a functional status in her home, or at least make her frail status as safe and functional as we can? Next slide, thank you. So physical therapy management. PTs can utilize standard functional tests to identify frailty. You may be familiar with one of these. Dr. Spivey had mentioned a few at least, like the tug test, the timed up and go. We use that. That has been a big predictor of falls. We use a 5 repetition chair rise test to test for functional strength, a 6-minute walk, a 2-minute walk. There's so many functional tests. They're based on normative values for age and gender. Then once we're picking and choosing the deficits that we find, then the focus is going to be on an individual exercise program, ideally 2 to 3 times per week. Resistance is huge. Major muscle groups with early intervention is key. Resistance exercise appears to be the major weapon to combat frailty. In the home, we're using exercise bands and free weights, body weight exercises, squats and lunges, sit to stands. We're looking at an 8 to 15 repetition mode with, like I said, about 2 to 3 times per week. Aerobic conditioning in the home is so important. Gait training, boxing, marching. In the outpatient setting, you're using the bike and the new step. On the inpatient side, we're getting these patients up and out of bed and walking in the halls. We want to see if we can work them into that moderate intensity, that 5 to 6 range on that 0 to 10 scale of intensity. Of course, balance is so important to prevent falls. This is tricky. We may need a little bit more supervision and skilled physical therapy to execute these dynamic balance challenges we're putting these through, but most definitely can be starting on basic exercises to improve your balance. We know with balance training, just like with resistance training, it's going to get stronger and better. Flexibility is very important for functional reach. ability to dress, reach your shoes, hygiene tasks. All of these things are important, especially if we're able to get to perform hygiene tasks safely. Right there, we're going to be a piece of preventing UTIs. Posture, of course, is important. We're focusing on upright, neutral spine to decrease falls, but also to improve breathing patterns with our folks with pulmonary compromise, improve digestion. And then lastly, adaptive equipment needs can be a game changer when it comes to remote independence with gait and transfers, bed mobility, showering, and accessing the community. I think that's it for the physical therapy portion. And if we're moving back to Norma, despite our best efforts, Norma is back in the hospital again, and I'll be transitioning to Dr. Perlovsky for that. Thank you.
Thank you. So, hey guys, I'm Mike Perlovsky. I serve as the Market Medical Director here in the Denver Metro, and I've been a hospitalist here, hanging out about 12 years now, seeing a lot of folks like Norma. So in this case, one of my ED colleagues calls me and says, I have this nice lady for you who's coming in with some pretty substantial lower extremity edema. You know, the x-rays showing some mild pleural effusion. There's a light oxygen requirement, pretty bread and butter admission for us. But to steal Margaret's term, you know, when we admit these patients, we almost become frailty detectives. And for any hospitalist, it's important to start thinking about discharge from the very first part of the admission. So right off the bat, I see some red flags that are contributing to frailty. And the biggest one for me is the 4 recent admissions. And if you know it, those admissions are for infections, for weakness. And what do we do when these folks come into our hospitals for these kinds of pathologies? Well, we load them up with fluid, right? And we see a lot of these folks come back with volume overload issues because it's very difficult to sometimes assess if somebody's volume overloaded at that discharge from those initial admissions. So clearly they've tried diuretics. The husband's been holding him because it makes her pee too much. She's getting up and down. And I see other things that will contribute to that volume overload. First of all, the history of sleep apnea, the lack of mobility, you know, all these things that put her at risk of volume overload. Now, I look at other elements of her social history. I look at the fact that she lives on the 2nd floor, or at least that's where her bedroom is. She's going to have to climb up to get there. There's also concerns with her medication regimen. As Dr. Spivey previously said, she had been switched from the 70-30 to a basal bolus regimen. Well, as you can see here, she's not on that anymore. She never made that change. She's still taking the 70-30. So she's at risk of hypoglycemia at home. Now, she's lucky to have good family support, which a lot of our patients are, you know, not as fortunate to have. And of course, the other factor is dementia, which complicates everything. That tells me right off the bat that I'm not going to just have to educate her. I'm going to have to educate her caretaker, who in this case is her husband. So again, just adding to the complexity of the situation. On the initial evaluation, we of course do the medical management piece. We see that she has a normal ejection fraction on her echo, which is good because we don't have to start kind of going down that whole cardiology path. But so after we diurese her, there's the other things that I mentioned earlier as pertain to thinking about discharge right away, which means that we have to get physical therapy involved right off the bat. The earlier we get them involved, the earlier we can start that process of determining how to get her home safely. There's, of course, delirium precautions, and I'm not going to get too much into that because there's a wonderful grand rounds that happened, I believe, last month, and so my plug for it is you can go and watch that on demand. But you know, with delirium, I think of things that can prolong hospitalization, which can further contribute to weakness, which can further contribute to a very difficult dispo. So those delirium precautions become paramount. And of course, we optimize her medication. We get her on that basal bolus regimen. And the next phase is engaging our clinical team. You know, and that starts from nursing. We need to make sure that our hospitalists are in constant communication with our nursing team. Our nursing team is our eyes and ears, and they are the ones that can provide the best insight on a minute by minute basis of what's happening with that patient. Overnight events, confusion, all these things that are very hard to pick up in that small time that the clinicians are in bedside in the patient's room. Discuss with physical therapy. How do we get this patient home safely, right? We have to discuss with case management. What are the resources we have available? Is home health an option? What are the SNF resources? And of course, pharmacy to help optimize medical regimens. So with that, I'm going to hand off to Leah to talk about the nursing course.
Hello, my name is Leah Wulfekoetter. I'm a nursing director here in Lincoln, Nebraska. And so I want to share how we apply age-friendly care principles in the hospital setting from a nursing perspective. So upon admission, we would perform a thorough evaluation, including the educational evaluation, specifically related to the missing medication doses. This would be crucial for the patient, but as you said, for the caregiver, her husband as well. We would conduct a social determinants of health evaluation to understand any barriers for care at home. So considering what matters, we would learn that what mattered most to Norma was that she did not want to go to a nursing home, and her cat is what brought her joy. So we would, as you can see, write this on the whiteboard. This would communicate it to both the patient and her care team. We would use this for motivation, guide interventions, and set goals for her. So we would also use a heart failure zone tool to help them recognize and respond to changes in her condition. We have an amazing care team and social work team that would be involved to address any social determinants of health needs. As medication adherence was a concern, we would work with the patient and her husband to understand why these doses were missed. Was it confusion, difficulty opening bottles, access, cost? In this case, her husband was worried about getting up at night and falling. So we would work with, as the provider and the pharmacy to schedule the doses maybe earlier in the day, and then hopefully decrease her trips to the bathroom at night. We would implement, to address mentation, we would implement our delirium prevention protocol, ensuring hydration, sleep hygiene, and providing that cognitive stimulation. Mobility, we have an amazing PT and OT team, and they would perform an early evaluation, continue with regular reevaluations and treatments. And we'd encourage her to get up with all meals and maintain her strength and independence. And we would definitely address fall prevention, which leads us to our poll question. What fall precautions would be most important for this patient? You guys did great. Yes, so fall prevention is multifaceted. So we use the bed and chair alarms to help remind them to ask for help, because there's a lot of extra cords and barriers in hospital settings. We make sure that our call light is always within reach, using the gait belt and walker specifically, or especially since she uses a walker at home, making sure that she uses it correctly and knows how to be safe while using that. If she has impulsivity or confusion that would cause increased need for locating near the nurse's station, we would do that. PureWick was the one I was trying to catch you all on, and you guys caught that. So while we may use the PureWick at night to promote sleep, we definitely would discourage it during the day because it would impair her mobility goals. So that wraps up our inpatient care. So I will pass it back to Dr. Perlovsky. Thank you.
Thanks, Leah. And I believe I have another poll for you guys. Am I correct in that? And that poll is, how do we create a safe discharge for this patient? And as you guys can see there, we have a wide distribution of answers, and they're all ways to help get this person home safely. But follow up and handoff are some of the biggest elements of that, and I'm going to talk a little bit about that right now. So there's a few things that, as we've diuresed normal theoretically to euvolemia. So we've taken care of the medication part of it. The legs are looking good. She's breathing okay. She's off her oxygen. So now we have to find a way to make sure she stays out of the hospital. So we have to work with patients and families to make sure that we set them up for success. So if the husband's not going to give that Lasix because he's worried about her peeing at night, well, certainly we can adjust the timing of that medicine to be closer to the morning. But the other question we can ask is, can we make it PRN? She has a preserved ejection fraction. She's euvolemic. We could, in theory, think that she's coming in volume overloaded because of the past hospitalization. And I say that because oftentimes we just discharge these folks on a medicine and call it a day. And I think some tailoring and careful consideration needs to be considered. We'll also put her on the basal bolus regimen and provide education for the husband as to how to administer and why it's important. Now, our physical therapist did recommend skilled nursing for this patient, but as we've talked about before, that's not in line with her husband's goals of care. So how can we make the best case for her for home? And that's where, again, we engage our clinical team in terms of physical therapy, making sure that we talk about any kind of equipment needs that they might need. We talk to case management. We make sure that if home health is an option, that we get that arranged and that we give her all the services that she would need at home. And then there's the handoff, which is probably the most important part, because if this patient's going back to see Dr. Spivey, I need her to understand my concerns in the hospital and the things to watch out for. And there's a variety of ways of doing this. Ideally, if it's somebody in our system, we can send a discharge summary, and that's a real-time handoff, but that's not always an option. So sometimes we got to pick up a phone and Google an office number and give a PCP a call just to make sure that they know how concerned we are about the frailty of this patient. And the other thing that I tell all my patients is, even if I call, even if I make an appointment for you, it's kind of like what we do in medicine: confirm, or sorry, believe but verify. You are your own best advocate, and make sure that that Norma's got that patient or that appointment set up when you get out of the hospital. And we want those folks to be seen as early as possible, ideally within 48 hours. That's not always feasibly an option, but the more you encourage the patients and families, the more likely we'll keep this person out of the hospital. And with that, I'll hand it back off to Dr. Spivey.
Great, thank you. So as we continue on, now Norma has gone back to home, and here she is in my clinic again. So I am following her closely because she has a lot of different things going on. And over the course of multiple visits, she ends up getting a updated eye exam with updated glasses. She has a ENT referral for her hearing loss. Unfortunately, although she has some mild sensorineural hearing loss, they do not necessarily recommend hearing aids at this time. We continue PT and OT because she still remains a high fall risk. And we made a few more adjustments to her medication. So I don't know if you recognized when we were looking at her medications to start with, she was on 80 milligrams of Prozac, which is a really high dose for a geriatric person. So we reduced that dose. We also discontinued loratadine. She didn't really need a daily antihistamine. And while the second generation antihistamines are safer than things like Benadryl, they are still higher risk medications. We discontinued her gabapentin because she wasn't actually having any pain. And we stopped her fish oil in part because it was taking up so much space in her pill packs that they had this kind of difficulty getting them in. And then thinking about her time to benefit, it really didn't make sense for her to stay on that medication. Obviously, one of the biggest things that we want to do is monitor and make sure that we're following up on her diuretic timing and adherence and nocturnal urination, since that's been such a problem for her and her husband. So 1 month after her hospitalizations and sweeping changes, we see her back and she's had increased adherence to her medications, specifically with her diuretics and her insulin. Her mood is actually improved even on a lower dose of her depression medication. She's less confused with once daily medications. She has fewer falls. She hasn't had any UTIs, and her hypo and hyperglycemia are much better managed with her lower insulin dose. All right, Margaret.
Thank you all so much. And I just want to take a moment to thank all of our panelists and ask them to come back on video, because we do have just a couple of minutes left for Q&A from this fantastic session that you all have contributed to. So the first one I want to put out there to you all, and Mary, I'm going to put this one to you. Are there any new devices or preventative measures to reduce the impact of falls in the elderly? So when you're seeing them in the clinic after they've maybe been with Mike and Leah after a hip fracture or rejection, right? They've had that surgically repaired. Are there any new devices or preventative measures to help, and maybe Kim in the outpatient space as well? Anything that you guys see?
Yeah, so nothing profoundly new that I'm aware of, unfortunately. We know that PT and OT are kind of the standard, gold standard things for helping reduce falls, making sure that people have a home safety evaluation, are wearing non-slip shoes, have their DME in place. Some of the things that we used to say, we used to have kind of a plug for hip protectors, but unfortunately over time we found that those actually haven't really helped prevent hip fractures. So nobody's walking around with their big hip protectors anymore. So yeah, mainly it's making sure people have their DME, their home safety equipment. The last thing that sometimes we forget about is that cataracts can actually be a really high risk for falls. So if your patient has some cataracts that they haven't had removed, you can recommend that, and that has been shown to reduce falls.
If I can interject also briefly to answer that question, I feel like this is a great opportunity for put a little physical therapy plug in there. I think it's great to on a yearly checkup with patients in the physician offices to just make a statement. Have you ever seen, ask a question, have you seen a physical therapist before? Instead of waiting for something catastrophic to happen with a fall, how about we get you in early and just go for a evaluation? If they can get to an outpatient setting, just a simple evaluation of their strength and balance. Maybe they're doing great and maybe they don't need us, but we're going to send them home with a take home of a good set of exercises. If they're homebound, we can certainly do a home healthcare evaluation. So yeah, I think it's great to be proactive and preventative rather than waiting for something and then have to be reactive. Refer to your physical therapist. Get to know your therapist in your community.
Thank you, Kim. And I'm going to close us out with one last question because I know we are at time, but it so perfectly reflects some of the conversation that we actually had as a group of clinical professionals while we were coming up with and reviewing this case study. It says, well, I understand the purpose of the Beers list. I find it frustrating in terms of control of pain and sleep. Some people can't get by without TCAs, opioids, benzos. Try to lower the dose as much as possible, but would love to hear, I know Dr. Perlovsky, Dr. Spivey, we went back and forth on this a little bit, and Leah's taking care of this patient on the floor, right? So would love for you guys to speak into this one a little bit before we close out.
Sure, I'll start with it. So yes, so I mean, the beers list is there, and I know it's a huge list, and it just keeps growing every time it comes out, and that has been a little bit of a frustration. But yeah, you're the clinician at the end of the day, and there are beers list medications that people need, and it's talking about, again, everything in the context of those 4 M's, what matters to the patient. If they're saying, I understand that I could have a risk of falls, but I still want to be on my amitriptyline or my oxycodone, then yeah, I mean, optimizing whatever you can using the non-beers medications is ideal. But there are times when you use a Beers list medication, and as a clinician, you just do the best you can with what you have.
I'll also add that I think that there's an element of fear anytime somebody is asked to stop a medication they've been on for a long time. And a big part of that is establishing trust. In the hospital medicine space, you're often seeing them for a couple of days. And I think there's opportunity certainly to establish that relationship there. But that's when on our side, we have to empower that relationship with the primary care physician and make sure that this is something that at least continues in the discussion. Again, back to what I talked about on the handoff, when I call or write a discharge summary and forward it to the primary care doc, and when I speak to in this case, the husband, please talk to your primary care doc about this. This needs to be an ongoing conversation.
Leah, any comments on that from a nursing perspective when this patient is with you in the hospital over that night shift where you hope they are sleeping?
We just really focus on the non-pharmacological interventions, if there's any of those. So we have what we call a sleep kit, comes with the eye mask, earplugs. We have fans in every room. It's just, those little things to help promote that sleep, keep the room dark, minimize interruptions if possible. But like Dr. Perlovsky said, building that trust, that's also helps with the what matters. So we really try to connect, we're strangers coming into this. So trying to connect fast in a short period of time is, it's a big challenge, but something that we are passionate about. So I think that helps overall.
Very well said. Very well said. Well, thank you all so much for your time. And again, for the expertise that you brought to this panel, and really, and most importantly, the care that you bring to our patients each and every day. And Barbara, I'll hand it to you to close us out.
Thank you so much. I think this just embodies the value of our teamwork, physicians, advanced practice providers, nurses, PT, OT, respiratory therapy, pharmacy. The list goes on. Please, that was not exhaustive, and how valuable we all are to helping Norma achieve what matters. So I think there are a couple of questions, John, in the chat about accessing CME that you have addressed, and really look forward to the next Grand Rounds. It's focused on our age-friendly topics. I think that is on June 27th.